Good evening, everybody. Welcome to Dil Se Dil Tak. We are live from the city of Bangalore today. This is Dr. Indranil, your host for the day. I just want to give you important statistics. Indians fall prey to cardiovascular disease about 10 years ahead of the West. Not only that, in India, it is more alarming. One person dies of cardiovascular disease every 33 seconds. IPCA has launched an initiative to create an awareness among the public so that we can have a healthy heart lifestyle. With Dil Se Dil Tak, we have brought the elite medical fraternity, the top cardiologists of India on a platform so that we can discuss the different aspects of healthy heart. Today we have an elite panel of cardiologists from Bangalore who will shed more light on this, how to lead a healthy life, how to prevent a heart attack, and what exactly we do if we actually have a heart attack. First, we are live from the City of Gardens, which is Bangalore. Let's start with a video which shows the different aspects of Bangalore. Let's have a look.
Bengaluru, the capital city of Karnataka, which was once called the Garden City of India. The city is known for its parks, nightlife, and beautiful architectural masterpieces. Like Vidhana Saudha, a neo-Dravidian legislative building, former royal residences include 19th century Bengaluru Palace and Tipu Sultan's Summer Palace, an 18th century teak structure. But today, it's the center of India's high-tech industry, which over a period of time has witnessed a large-scale population migration from various parts of the country. Due to rapid industrialization, lifestyle changes, diet, air pollution and stress, Bengaluru is witnessing a surge in cases of heart diseases. Today, Bengaluru is witnessing a steady stream of young patients, those in the age group of 16 to 40, being admitted with heart attacks. Doctors say they admit about 150 young patients, about 8 of whom are below 25 years of age every month. This translates to a minimum of 3 to 4 cases every day. Today, to talk on this, we have a panel of renowned cardiologists from Bengaluru live on our talk show, Dil Se Dil Tak, Healthy Heart, wherein they will educate us about what we should do and what we should not do to keep our heart healthy, to which will save us and our loved ones from the menace of heart diseases.
So Bangalore has brought the IT revolution in India. So let's see now whether it can actually lead a revolution on healthy heart lifestyle in India. To discuss more about this, we have our first panelist. Let's introduce him. He's an eminent personality across India globally. He is the professor and head, Department of Cardiology and Cardiac Electrophysiologist, MS Ramaiah Memorial Hospital, and professor of cardiology, MSR Medical College and Teaching Hospital, Bangalore. Let's welcome first Dr. V.S. Prakash. We'll start with a video with a message from him. Let's see the video.
Human body and its complexities fascinates all of us. But a young mind got so much fascinated by it that from early years of his life, he had decided to devote his entire life in alleviating human suffering through minimal surgical intervention with outcomes which will make his patients enjoy the beauty of life for long. Presenting to you the journey of a renowned cardiologist whose goal is to set up a state-of-the-art division of cardiac rhythm management and pacing, which is of international standards, so that he can serve patients from all around the world. Meet Dr. V.S. Prakash, who currently heads the Department of Cardiology and Cardiac Electrophysiology at MS Ramaiah Memorial Hospital in Bangalore since 2005. Dr. V.S. Prakash completed his MD in Medicine from Bangalore Medical College in 1986 and DM in Cardiology from Kasturba Medical College, Mangalore in 1993, post which, in his pursuit for excellence, Dr. Prakash has obtained many international renowned certifications from globally renowned medical bodies. To name a few are training and fellowship in advanced cardiac electrophysiology for complex heart rhythm problems at Veterans General Hospital, Taipei during 1998 and 1999, which laid the foundation for cardiac rhythm related work back in India. Fellowship in SCAI Society for Cardiovascular Angiography and Interventions, USA. Fellowship in ACC, American College of Cardiology. Fellowship of the ESC, European Society of Cardiology. Dr. Prakash has a wealth of experience and clinical expertise in performing coronary interventions, including complex coronary angioplasties. Dr. Prakash is among the few cardiologists in India who are well versed as primary operator for various arrhythmias, including AVNRT, WPW, to name a few, including all advanced procedures and implants. Highlights of some of the remarkable work he has done in the field of cardiology are: Dr. Prakash was first in India to perform catheter-based ablation for atrial fibrillation in 1999. Dr. V.S. Prakash has worked at several reputed hospitals in India since 1994. To name a few are consultant cardiologist at Malya and St. Philomena's Hospital since 1994. Dr. Prakash has also served as observer in cardiac clinical electrophysiology at several hospitals in USA and Germany, like Brigham's and Women's Hospital, Boston, Massachusetts, USA in year 2000, Cleveland Clinic, Cleveland, Ohio, USA in year 2000, Grenouille Cardiology Institute, Indianapolis, USA in 1999, St. George Hospital, Hamburg, Germany in 2003, Florida Hospital, Orlando, USA in 2004, Center for Atrial Fibrillation, Cleveland Clinic, Cleveland, Ohio, USA in 2005, St. Luke's Hospital, Aurora Sinai Hospital, Milwaukee. He had been invited as faculty at various national and international cardiac electrophysiology and pacing meets. To name a few are faculty at Asia Pacific Atrial Fibrillation Symposium, held at Seoul, Korea. Faculty at Asia Pacific Cardiac Electrophysiology and Pacing Symposium, held at Jakarta, followed by faculty at ISC Con, Indian Society of Electrocardiology Conference. Then at Asia Pacific Heart Rhythm Meeting in Hong Kong in 2012, Beijing in 2013, Tokyo in 2014, and Melbourne in 2015. He is a life member of many prestigious medical associations like Cardiological Society of India and CSI Bangalore Chapter, Indian College of Electrocardiology. He is also member of Heart Rhythm Society. His articles on cardiology were published in many peer-reviewed journals and had been principal investigator in over 15 research activities. To name a few are Athena Study, Bi-Relay Study, Inspra Study, and Aristotle Study. Dr. V.S. Prakash, apart from being a busy cardiologist, holds a strong passion for good health because he believes that in a healthy body lives a happy mind, and he firmly believes health is wealth. In the past, he had been invited as a speaker at various corporates to educate people on how to keep good heart health. Dr. Prakash was awarded the Mahindra & Mahindra Nightingale Award for one of the 10 leading personalities in the field of medicine in 2003. Let's listen to Healthy Heart message from Dr. V.S. Prakash.
Hi viewers, I'm Dr. V.S. Prakash, Head of Cardiology at Ramaya Memorial Hospital, and my message to the population, to the people, would be to take care of their health, primarily in the form of prevention, because whatever we do today is we are only chasing the problem rather than taking the bull by the horn. I think the best way to take care of your health would be to inculcate healthy lifestyle, regular exercise, proper diet, most importantly avoid smoking, avoid fast foods, which is really bad today, which has become the way of life for all the youngsters, and sedentary lifestyle is something. And I'm also concerned about, you must have routinely been seeing that people suddenly collapse. They're sitting, they're watching a TV or they're reading a newspaper, and within seconds they are dead and gone. This is what we call a sudden death, and usually it occurs because of cardiac arrest and sudden cardiac stoppage of the heart functioning. This is something that is a big problem that is going on in the world, and at the present moment we are still not able to get over this issue, find out who are at risk, and really try and bring about corrective measures. But one message that I would like to tell the viewers would be regular exercise has clearly shown, consistent regular exercise has shown sudden cardiac death to come down by 50%. So that is the importance of regularly exercising and taking care of your lifestyle. Thank you.
welcome Dr. Prakash to the stage, please. Welcome, Dr. Prakash. So, Dr. Prakash, we have seen that you have the experience of working in US, Germany, Taipei, so along the world, I can say. But in India, what have you seen which is different so that we are so much prone to cardiovascular disease?
Yeah. See, the risk factors for cardiovascular disease are the same everywhere. Smoking, dyslipidemia, hypertension, diabetes, obesity, it's the same thing. It doesn't change. But yes, as you were pointing out, we have disease occurring in the young. So we have an accelerated disease process. That is what we notice in the Indians. The disease process rapidly progresses, one thing, and catches the young. The age of onset of the disease is very early. That's another important thing, different from the rest of the world. There, they probably start seeing the disease at about 50 or 60 years. Here, we start to see at 32, 35 years, maybe even younger. And not only that, the case fatality rate in Indians is much higher because probably preventive measures are not in, and their lifestyle, and it catches the young. So, many of them have plaque rupture and acute MI. So the collaterals have not developed, and the whole, the heart is still not ready for this kind of impact. So the case fatality also is much higher. So rapid disease progression and age of onset plus the case fatality is what really makes the Indians stand apart from the rest of the world, and that's the reason why we are at a higher risk.
So lack of exercise is a big cause.
Sedentary lifestyle is global. They say laziness is, it's a standard norm in the world today. It's more of a rule rather than an exception. It's there all over the world. However, yes, in India, the problem is and there's also something which is probably occurring at the young itself, the maternal health, and then what really happens at that point. They find that there's early onset of obesity also in the children. So this also could have an impact on early disease onset in the Indians, which could make a difference compared to the rest of the world. And definitely our lifestyle today has changed quite a bit. All of us are sedentary, and that would make an impact. And metabolic syndrome. Metabolic syndrome also is considerable in the Indians, what you call as central obesity. See, you see most of the Westerners are generally obese, generalized obesity. Here you see most of us have central obesity. You see everybody having a pot belly, isn't it? That's a very common thing. Central obesity is the biggest issue which you see in the Asians, and primarily in the Indian subcontinent.
That's the YY paradox, as we know.
Exactly.
The best thing was that we saw the crunches and the pull-ups you were doing. So I think the audience should be encouraged, and they should also follow your lifestyle. That's the best part in the video. So thank you, Dr. Prakash. We'll definitely come back to you again during the panel, and we'll take the discussion forward.
Thank you.
Thank you very much. So next, we'd like to introduce someone who is an eminent personality, an eminent cardiologist of Bangalore. He's the professor and head of department of cardiology at St. John's Medical College and Hospital. His name is Dr. Kiron Varghese. So first, we'd like to see a video on him, his message, what he does regularly, and then we'll definitely go and meet him. Let's see the video.
What started as a dream of becoming an engineer for a young boy changed into a reality of being an eminent and outstanding gold medalist doctor today. He is a renowned cardiologist known for his ethics when it comes to treatments of his patients. Meet Dr. Kiron Varghese, whose mantra in life is to be happy and healthy. He personally feels that if you want to be fit, then eat less and exercise daily. He practices what he preaches, and on weekends he do cycling for approximately 50 to 60 kilometers. Apart from his daily routine of walking, cycling and a special initiative to be near nature by working on his rooftop garden. The highlight of his routine is that he prefers to walk wherever he goes during the day to be fit. Dr. Kiran believes in spreading happiness in people around him and society at large. His relentless and untiring service to humanity by serving poor, needy and old patients is acknowledged globally. He had organized free angioplasty camp during January and February 2019 for economically underprivileged patients. He even did free cardiac intervention along with free 5 stent for a poor homeless person living in his vicinity. Recently, Dr. Kiran set another remarkable feat by doing an angioplasty on the oldest man, Mr. Muniappa, the news of which was published in all major newspapers, including Times of India. Dr. Kiran is working as Professor and Head of Cardiology at St. John's Medical College Hospital since 2013. He did his MBBS from St. John's Medical College, Bangalore in 1982, followed by MD in General Medicine from Bangalore Medical College and Research Institute in 1987. He further went on to do his DM in Cardiology from Sri Jayadeva Institute, Bangalore, where his dedication and hard work made him excel in all his exams, and he secured first rank during his DM exams in 1992. In his endeavor of upgrading his skills, Dr. Kiran did specialized trainings in the field of cardiology from globally renowned institutes such as Fellowship in Interventional Cardiology from Sinai Medical Center, Los Angeles, USA. He is also fellow of many reputed national and international associations. To name a few are, he is fellow of the American College of Cardiology, FACC, fellow of the Indian College of Cardiology, FICC, fellow of the Cardiological Society of India, FCSI. He is also life member of Association of Physicians of India. Dr. Kiron Varghese, in his medical career, has a distinction of working with some of the leading hospitals of India and world. Post his DM, he started as Senior Registrar Cardiology at Malya Hospital, Bangalore from 1992 to 1994, followed by working as Consultant Cardiologist in Chest Diseases Hospital, Kuwait from 1994 to 2000. Then he joined as Interventional Fellow at the Sinai Medical Center, Los Angeles from 2000 to 2001, and since 2002, he is associated with St. John's Medical College, Bangalore. Dr. Kiran's area of expertise includes interventional cardiology, peripheral interventions, and preventive cardiology. Dr. Kiran has deep interest in research and has worked as primary or sub-investigator in numerous national and international trials. He has over 30 full paper publications and over 60 abstracts published in reputed journals across the world. To name a few are: use of coronary hardware in peripheral vascular interventions, necessity fostered ingenuity, is it solution enough? In Indian Journal of Heart 2018. Dr. Kiran has also written a chapter in a book and authored a book titled Therapeutic Embolization. Apart from being a busy cardiologist and a rhythm specialist, Dr. Kiran loves to find time for his love for music, singing and playing guitar.
And the only explanation I can find is the love that I've found ever since you've been around.
Let's listen to a healthy heart message from Dr. Kiron Varghese.
Good morning, sir.
Very good morning to you.
Any message for the patients, because heart disease is the number one killer in the world. Although there is rising awareness, but still the rate of death is very high with heart diseases, and it is very sudden also.
Right. So India is probably among the highest rates of heart disease in the world. It may not be much of a surprise if I tell you that the maximum number of obese patients are in America, but India is at number 3 in that position. Yes, and I think that is partly contributing to our increased heart disease, and it's because we eat the wrong type of food, we eat too much of that food, and we exercise too little. So whenever I tell my patients, you need to lose weight, they'll say, yes doctor, I'll start walking from tomorrow. But the key to losing weight is to eat less. The amount of calories in food is something which we don't realize, and the calories we burn while, say, walking is very small. You burn roughly 4 calories in a minute. One milkshake is 400 calories. one masala dosa varies from 250 to 1000 calories. So with one milkshake, that means you need to walk 100 minutes. So people walk for 30 minutes and come and have a milkshake. That just doesn't make sense. So anyone who wants to lose weight, it's all about eating less.
And eating healthy also?
Eating healthy is probably second, because once you lose weight, automatically your blood sugar, your blood pressure and your cholesterol will improve. So losing weight is of fundamental importance. What people do is they stop eating rice and eat chapati, the same caloric amount. It doesn't help. You need to reduce the amount of food that you eat. If you eat one peanut, you need to walk 2 minutes to burn the calories. So unless you're a manual worker, you just cannot burn the amount of calories that are required. So if you're serious about losing weight, you need to eat less, but you need to balance that with exercise, because otherwise the body goes into what is called the famine mode and reduces your metabolic rate, and you don't lose weight because the amount of calories that you burn at a resting state also will come down. So to keep your metabolism up, you need to balance it with adequate exercise. But exercise is not the key to losing weight.
Butterfly, my butterfly, I'll come home.
Welcome, Dr. Varghese. I think one of the message from the video was that the secret to a healthy heart is the playing your guitar. I mean, probably you can start a band one day.
Thank you. There's no time for that. They say medicine is a very demanding mistress.
Yes. Yeah, so today we have a very pertinent question, important question for you. Frequently we have seen that when there is a heart attack in an individual, that person mistakes it for just a gastric problem or a acid or something, and then they take all those medications like Eno and home remedies, and then they lose the important time which they might be suffering from a heart attack. So how do the patients differentiate between whether they are having a heart attack or a gastric pain?
So this is not an easy question to answer. Even experienced cardiologists can sometimes find it difficult to decide whether it's a heart attack or not, and sometimes need ECG and many investigations to really make a final diagnosis. But there are several points which can be of help to a lay person to decide whether this is something which needs attention or not. So I'd like to say what are the characteristics which make you suspicious that it could be a heart problem, and what are the points which point against it. So the heart is an internal organ, and the body handles pain in internal organs a little differently from the surface of the heart. For example, if a mosquito stings you, you know exactly where the pain is and where you can localize the pain. But for internal organs, the brain refers the pain to the surface of the body, and it's not very accurate. It's generally over a larger area and could be very variable. So as far as cardiac pain is concerned, it can be anywhere from the lower jaw up to the umbilicus. So it's a large area. Typically it's in the center of the chest or to the left side, left arm. That's what most people know. But it can also be on the right side, right shoulder, right arm, back, as I said, neck, and up to the umbilicus. Then the character of the pain, most people expect a very severe pain, which it could be. But sometimes it's just a burning sensation. So understandably, if you have a burning sensation in the upper part of the stomach, everyone will assume it is gastritis or gastric problem. In truth, there are so many other conditions which can also mimic cardiacs, not just gastritis. So it can be a burning sensation, it can be a heaviness. Very often it's just a weight on the chest or a constricting feeling in the chest, which may or may not radiate down one arm or the other. The duration is also important. Any pain that lasts less than 30 seconds is not cardiac. Any pain that lasts more than 6 hours is unlikely to be a heart attack, but very often, because it's not the full-blown attack, it can be a stuttering attack, it can last much longer than that, 12 hours, sometimes longer. But if it's been happening repeatedly, let the patient says that I've had this pain, this kind of pain lasting 6-7 hours, I've had it last week and last year and like 2-3 times a month, obviously each of those couldn't be a heart attack, right? So if it's been multiple similar episodes in the past, one would kind of ignore that. Now, there are a few points which point away from being a heart attack. Like I said, since the heart is an internal organ, you cannot make the pain worse by, say, pressing on the area. So if there is pain, now if a patient comes to me and say, Doc, I got pain here, and points with 1 or 2 fingers, straight away in my mind I'm thinking that this patient doesn't have a heart problem. Because as I said, it's a referred pain, it's generally over a large area. They come with a hand on the chest or it's a more diffuse area. If you press the area of pain and it gets worse, it's likely to be local. If it gets worse with movement of the arm or the neck or the shoulder, again, it's more likely to be musculoskeletal. So these are some points which can help you decide whether you need to take it seriously or not. In short, any kind of discomfort which needn't be pain, heaviness, burning from the jaw to this, associated with sweating, which is a very important associated symptom, should be taken seriously. Similarly, if it's associated with breathlessness or lightheadedness, these are symptoms which should prompt medical attention. And if it is a heart attack, then 50% of the deaths due to a heart attack occur in the first 1 hour. So that's the golden hour, we say. So it's important to get to a hospital with good medical facilities as quickly as possible if you think it's going to be a heart attack. A lot of the delay is because the patient thinks it is something else, then doesn't want to wake up his wife, doesn't want to bother the neighbor, but then after an hour or 2, he eventually does it. So if you think it is likely to be a heart attack, then get to a hospital quickly. The background of the individual also plays a huge role. Now, if a young lady, you say a 20, 30-year-old lady, who doesn't have major risk factors, has fairly typical symptoms, it's very unlikely to be a heart attack. Because the chance of a young woman who doesn't have risk factors, non-diabetic, having a heart attack actually is quite low. Because age is the strongest risk factor, and conversely, young age is the greatest protector also. We don't see this in male smokers. A lot of our young male heart attack patients are smokers. They come in their 20s and 30s with heart attack. So if you have multiple risk factors, even somewhat atypical symptoms probably warrant attention. And if you're young and without risk factors, probably we also don't go aggressively after such patients if we think that they don't have much risk factors. Of course, we are only talking of statistical probability of a heart attack, and only tests will tell us further. The key is probably keeping all the risk factors under control, as was mentioned by the earlier speaker, and regular checks. So if you're a diabetic, and you should probably go for a regular checkup, and your cardiologist will assess that and tell you what the probabilities of a heart problem is, and if that is the case, how to take preventive measures.
Okay, good. Thank you very much, Dr. Varghese. Thanks for your inputs. We got a fairly clear idea now how to differentiate. I think definitely the audience will take note of that. So we'll come back to you in the panel to have more insights on this. Thank you.
Thank you.
Doctor. So for the next panelist, we would like to introduce somebody who is one of the eminent cardiologists of Bangalore. He's interventional cardiologist, chairman and chief of cardiology, Trinity Hospital and Heart Foundation. His name is Dr. B G Muralidhara. First, we'd like to see a video on him, his message, and definitely we'll go and have a chat with him after that. Let's see the video.
Path-breaking and a trendsetter doctor who was born on 15th August, a true Indian at heart, who after completing his fellowship in interventional cardiology from Melbourne University in the year 1996, returned to India in 1998 instead of settling abroad with a clear goal to do something good for people of his motherland by bringing best quality of care, especially in the field of cardiology. Saving lives is mission of his life. Meet Dr. B G Muralidhara, the founder chairman of Trinity Hospital and Heart Foundation since the year 2000. Recently, he has also started menace Trinity Heart Hospital, a super speciality heart center in North Bangalore, Yelahanka, where he is currently working as Chief Interventional Cardiologist. In 2006, he set up first non-invasive CT angiogram facility in entire South India, thereby offering 1-minute painless angiogram to his patients. And in last 13 years, has done over 50,000 angiograms. Set up PPP model cardiac center with Jayadeva Institute, Bengaluru. His area of interest is coronary angioplasty, and in last 25 years, he has done over 25,000 angioplasty. He is trained in whole body intervention. To name a few are carotid stenting, renal stenting, peripheral stenting, and embolization procedures. He also holds deep interest in acute stroke intervention. Dr. Muralidhara has been conferred with prestigious awards for his commendable services in the field of medicine. Named them are Rajiv Gandhi National Award and Dr. B.C. Roy Award. He has also been honored by various social organizations like Lions Club, Rotary Club, GACS, etc. in acknowledgement of his service to the community. Recently, he has been bestowed with Shivaji Award by Karnataka Maratha Mahasabha. Dr. B G Muralidhara secured 3rd rank in university during his graduation from Gulbarga Medical College, followed by MD in Internal Medicine from Bangalore Medical College and Research Institute. He further went on to do his DM in cardiology from Kasturba Medical College, Manipal in 1992. As a part of upgrading his medical skills, Dr. B G Muralidhara did fellowship in interventional cardiology from Melbourne University in the year 1996. In past, he has served as an assistant professor of cardiology at NIMS Hyderabad and also as a consultant cardiologist at St. Vincent's Hospital located in Melbourne. Apart from doing active cardiac interventions, Dr. B G Muralidhara is also at forefront of spreading awareness about heart disease in India as preventive cardiology holds key for healthy India. In his mission to serve humanity, he had set up Heart Foundation and had organized over 400 free health checkup camps, along with other patient welfare initiatives in Bangalore, including rural parts of Karnataka. He had also conducted numerous public education programs, including health awareness lectures on AIR, All India Radio, Doordarshan, Udaya TV, ETV, and many other local cable networks. Dr. Muralidhara believes in sharing his knowledge and clinical experiences with fellow doctors because he believes shared learning holds key for a healthy India. Till date, he has conducted over 300 CME programs, delivered more than 250 guest lectures on various cardiology topics at various forums, including medical colleges and IMA conferences. Let's listen to Healthy Heart Message from Dr. B G Muralidhara.
Hi, I would like to say this to the public at large, not only for the heart patients. You have only one heart. Please remember that, try to save that heart. Once you have any heart problem or you think that you are likely to have a heart problem, get a checkup done well in advance so that you don't have to rush to the hospital with an emergency. Heart attacks are one of the leading problems that we face in India, and also in India we get heart attacks at a much younger age compared to the Western world. So the most important thing is, first thing is to prevent a heart attack. Never have a heart attack, never suffer from a heart attack. This you can do by maintaining a healthy lifestyle, by eating right kind of food and doing the right kind of exercise and walking and other activities. The biggest problem in our country is sedentary lifestyle. We stop playing the moment we go out of the college and we have a unhealthy lifestyle that is the cause of major heart problems. And once you get a heart attack, we have a concept called golden hours. Within the first 6 hours, if you reach the hospital, a heart foundation hospital, and take treatment, you can survive. Most people with heart attack can survive if the treatment is taken within the first 6 hours. Every 1 minute delay kills 1 lakh heart muscle cells. So the time matters, and delay is death, and money and time is muscle. So we need to reach the hospital as soon as we can, and also take treatment without any further delay. Heart attacks happen because of the blockages in the heart arteries called coronary arteries, because of deposition of fat. And what does the fat get accumulated there? It's because of eating the wrong food and not doing enough exercise. And once this is done, it takes about 15-20 years for these blocks to develop. They don't happen overnight. But by a procedure called angioplasty, we can remove these blocks in 20 minutes clearly. A 100% block can be reduced to 0% within 20 minutes. So a problem which you have acquired over 20 years can be cleared within 20 minutes, provided you reach the hospital in time, and that can save your life.
Welcome, Dr. Muralidhara, to Deal Se Dil Tech.
Hi.
So our question for today is that in today's scenario, I mean, the public knows that they have to do exercise, and doctors specifically stress on that whenever they're having a cardiac disease or hypertension, or they turn up in the clinic for lipid problems, whatever. You people always stress on that. But very few people actually, they start it, and very few people actually continue with that. So is there something the doctors can do which actually can make the patients follow? Because everything, success of the entire thing depends on the compliance to the exercise.
One is we need to emphasize to people about these things importantly, particularly when they're in the intensive care unit. They listen to the doctors very carefully when they're in the ICU. The moment they're out of the ICU, the moment they think they're safe, they don't think they need to bother about the doctors, they need to listen to it. So what I do is I make it a point to discuss with them on the day one, after the procedure, once it's over. In fact, I talk to them soon after the angioplasty, saying that somebody who is smoking or somebody who has diabetes, he has not bothered to take care of hypertension. I tell him that, see, you are here in the first place because of these problems. You don't want to come back again to me, make sure that you don't repeat these mistakes. If you repeat these mistakes, you're going to get a heart attack again, whether you like it or not. So the important message is the message should go loud and clear from the chief doctor, from the consultant who talks to the patient. Most of the time what happens is all these therapeutic life changes are left to the junior most in the team or to the paramedical people, and they don't give importance to the paramedical people in our country, which is an unfortunate thing. So the important thing is, as a lead consultant, we should take primary interest and talk to them about prevention. In fact, I tell many people, unless you promise me that you're going to quit smoking, I'm not even going to do an angioplasty. Because if I do an angioplasty and the guy continues to smoke, I'm sure he's going to come back with the reblockages. That spoils his health and spoils my reputation. So both are at risk. So I make sure many patients, particularly not only the heart attack patients, of course, we have little time. When they come with gangrene of the leg, problems with the leg, they refuse to smoke, stop smoking. I've taken them off my table and say, I'm not going to operate on you. So we need to drive home the point and make sure that they understand the importance of the thing. Also, I tell them it is not just taking medicines that is going to help you. It's equally important that you need to take care of your lifestyle changes. And also need to understand why you got the heart attack in the first place. It's not because of the medicines. You got the heart attack in the first place because your diabetes was not under control, your hypertension was not under control, you were smoking and your lifestyle was lazy. In fact, nowadays we say sitting is the new smoking. If somebody is sitting for more than 6 hours in a day, that is equivalent to the risk of smoking of getting a heart attack. So just sitting, simple sitting can kill the patient. So it's very important that we need to walk. Even people like computer professionals or software people who all the time sit, they need to understand that they need to walk. Minimum 8,000 to 10,000 steps per day is what is recommended. So if everybody walks 8 to 10,000 steps, most people can avoid a heart attack, at least delay the heart attack. So it's very important that we emphasize to them when they're in the critical case of illness, and also straight from the horse's mouth so that it carries some value. And also when they come to us every time, make sure and discuss with them about the lifestyle changes, whether they are doing it or not doing it, or the reasons for not doing it, and we need to emphasize upon them again and again. I scare my patients also when they come back for a follow-up, and if they are not doing it, be prepared to spend another 2 to 3 lakhs because you are going to get a heart attack sooner or later. So when I put the fear of death in them and tell them that, this is going to be a huge financial risk for you and your family if you don't change your lifestyle, most people do listen and most people follow. Yeah. But it's easier said than done.
So one of the things we have, one of the videos we are seeing in Singapore, there is a doctor, basically there is a patient group which he has. They come to exercise and he joins them in the morning for 10-15 minutes. In India, I think most of the patients treat their doctors as gods, next to gods. So can we do something like that? 5 minutes?
Well, we are no longer treated next to gods, we are also treated next to demons. So let us not get into that. In fact, see, I live very close to Lal Bagh. I used to go for a walking 20 years ago, but today I can't afford to go because I get to see at least 200, 300 of my patients walking in the Lal Bagh. So I find a lot of people, and then what happens is, not only they jog with us, they also do a free consultation on the path, and then it goes on. So it does help, but if it can motivate, see, anything that can motivate the patient, I think it's worth a trial. So if people are willing to do that, and if you can join, I have no problem in joining, I have no problem in encouraging people to do that. But basically, they need to understand that it's very important that the walking is any kind of physical activity is important. At least the recommended is 5 hours per week, minimum of physical activity, so that the metabolic parameters are taken care. And if they're overweight, of course, they need to do a little more. And also apart from the physical activity, it is also the food that matters. The kind of food that they use, and not eating enough fruits and vegetables is also one of the important risk factors for heart problem. So we need to emphasize on the food part also. It is nutritional assessment is required. They need to get a proper assessment and advice on the food that they eat also, which is also equally important. The other problem is in our country is people think that, like whatever the diet advice that is given, it's probably for a week or two, and once they're all right, they forget about it. So they need to understand that the diet changes that are advised, the lifestyle changes that are advised, it is for life, not for... Another thing I keep telling my patients is, as long as you want to live, keep doing these things, 3 things. One is regular exercise, limited food, and then tablets. The day you choose to die, you take a call that I don't want to live anymore, then you can give it up. And also remember that the day you give it up, your clock starts ticking. You can get into a heart problem, not only a heart problem, also a stroke or a gangrene or a vascular problem anywhere. See, and also I tell them some frightening statistics. Tell them that 80% of the diabetic people are going to die of a heart attack, half of the Indians are going to die of heart attack. Put some scary figures in front of them so that they understand and they realize the importance of not getting into this problem again and again.
Many thanks, Dr. Muralidhara, for your excellent inputs. Definitely we'll discuss more about that in the panel discussion today. Thank you very much.
Thank you.
Next, I would like to welcome an eminent cardiologist and personality from Bangalore. He is the Senior Professor of Cardiology, Head of Department of Non-Invasive Cardiology at Sri Jayadeva Institute of Cardiovascular Science and Research, which is a top-notch medical institute. So let us welcome Dr.T.R Raghu. And first we'll see a video introduction on him, and then we'll hear a message from him. Let's see the video.
Meritorious scholar, doctor who hails from a family of agriculturists. He stood 6th in entire state of Karnataka during his PUC examination and is also a recipient of India National Merit Scholarship by Government of India during his PUC and MBBS exams. A skilled trainer, researcher and result-driven eco-cardiologist who had an extensive experience of nearly 3 decades in the field of interventional cardiology. He is an expert in invasive and non-invasive cardiology, interventional cardiology, non-coronary interventions, pediatric interventions, and diagnostic cardiology, encompassing congenital heart disease. His mission in life is to bring best medical treatment for his patients and people of his native town. That is why once a month he renders his free medical services for people of his hometown. He believes that if all doctors at least give once a year free medical service to natives of their village or town, then India will have a better healthcare scenario. Meet Dr.T.R Raghu, who is presently working as Senior Professor of Cardiology, Head of Department of Cardiology since the year 2005 at Sri Jayadeva Institute of Cardiovascular Science and Research, a top-notch medical institution considered as one of the world's leading cardiology hospitals. Dr. Raghu completed his MBBS in 1983 and MD in Internal Medicine from Bangalore Medical College in 1988 respectively. Further, he did his DM in Cardiology from Kasturba Medical College, Manipal. Dr. Raghu started his medical career in 1984 as Junior Resident at Ambedkar Medical College, Bangalore, followed by working as Lecturer of Medicine at Adi Chunchanagiri Institute of Medical Sciences, Mandya, and then he worked as Senior Resident Cardiology at KMC Manipal, from where he did his DM in Cardiology. After which he joined MS Ramaiah Institute of Cardiology, Bangalore as Assistant Professor Cardiology. Then, in 1993, he joined Sri Jaydeva Institute of Cardiovascular Science and Research as Lecturer of Cardiology. Got promoted to Assistant Professor of Cardiology in 2001 and then since 2005 serving as Professor of Cardiology. Now Head of Department Cardiology since 3 years. Dr. Raghu's penchant for knowledge upgradation made him earn many internationally renowned certifications from globally renowned medical bodies. To name a few are Fellowship from Indian College of Cardiology in the year 1996, Fellowship of American College of Cardiology in the year 2011, Fellowship of European Society of Cardiology in the year 2014, Fellow of Society of Coronary Angiology and Interventions in the year 2015. Dr. Raghu has performed over 39,000 coronary angiograms, over 8,500 coronary interventions, including PTCA, stenting, rate ablation, and direct stenting, over 3,800 balloon valvuloplasty procedures such as PTMC, PABV, PTVP, and PBPV. He has also performed 100 procedures in congenital heart disease such as pulmonary balloon valvuloplasty, aortic balloon valvuloplasty, coarctation of aorta, PDA, and ASD closure. In addition to this, he is a skilled trainer with the merit of training the students on cardiology, acted as an evaluator for evaluation of thesis, for awarding PhD degree from last 3 years for DM cardiology students. Dr. Raghu is also working as MCI inspector for assessing the quality of facilities and training for DM cardiology in various medical colleges of India, and as DM examiner for various medical universities in India for awarding DM degree. In the past, he had worked as member of Credentials Committee of Medical Council of India from 2012 to 2014. Since last 3 years, he is also serving as member of the Super Speciality Board of Sri Rajiv Gandhi University of Health Sciences. Dr. Raghu has over 25 paper publications in his name, which were presented at various national and international conferences. Long-term results of multiple and multi-vessel PCI, published in Cardiology Update book in year 2012-13. A patient with rheumatic heart disease, presented with central cyanosis due to acquired methemoglobinemia during late pregnancy, a rare association, published in Journal of Disease Research in year 2013. Dr. Raghu has served at key positions in several medical associations, like he was Honorary Secretary of Indian College of Cardiology, Vice President of Indian College of Cardiology, Honorary Treasurer at Indian College of Cardiology. Presently, he is President-elect for Indian College of Cardiology for the year 2019-20. He is also a life member of many medical bodies. To name a few are life member of Cardiological Society of India, Indian Academy of Echocardiography, Indian Medical Association, Indo-French Interventional Forum, Indian College of Interventional Cardiology, worked as a founder member, Indian College of Cardiology. Dr. Raghu is also actively involved in conducting free monthly cardiac checkup camps in different parts of Karnataka under the auspices of Rotary Club of Channapatna since 1996. Let's listen to Healthy Heart message from Dr.T.R Raghu.
I am Dr.T.R Raghu, working as Professor and Head of Department of Cardiology, Sri Jaydeva Institute of Cardiovascular Science and Research. And ours is one of the biggest cardiac centers in India. We see about 7,200 to 2,000 patients in a day. And I have got almost 25 years experience in Jaydeva. As per my experience, commonest risk factor for heart disease, especially heart attack, in India is diabetes, hypertension, smoking, and hyperlipidemia and stress. In part, these are the 5 important risk factors. And of late, pollution has become an important risk factor. People who don't have risk factors, because of pollution, all these microparticles goes to the lungs and goes to the blood vessels and cause there is increasing incidence of cardiovascular disease.
Welcome, Dr. Raghu, to Dil Se Dil Tak. Sir, we have a pertinent question for you. Especially in India, there is a big problem that a lot of young people are developing coronary artery disease. So, what are the factors which are responsible for this? Does genetics have a role to play in this, or is it just the lifestyle? which are responsible for development of CAD in the young. Does genetics have a role to play in this?
See, definitely, because whatever the common risk factors, modifiable risk factors play a role, and there are non-modifiable risk factors like age, male sex, and hereditary, and these are all, and familial hyperlipidemia. And to study this premature coronary artery disease, in fact, Jayadeva Institute of Cardiovascular Science started a research on premature coronary artery disease from 2018. My colleague Dr. Rahul is doing a study, and we have included now up to date 2,500. It's a prospective study. It is going to cover genetic markers, going to non-modified risk factors, and we are doing this study in association with St. John's Medical College, Indian Institute of Science, and we are studying the genetic markers in addition to the non-modified risk factors. Whatever the present observation in these 2,500 patients, we saw modified risk factors like diabetes is only 10% of the patient, hypertension is 11% of the patient, and hyperlipidemia is only 13%. And 50% of the patients are smoker in this premature coronary artery disease who are less than 40 years. Another 16% had hereditary family stiff coronary artery disease. And 25% of the patients, there were no risk factors. And that most of these patients, what we have done, most of them are manual workers, they're drivers, auto drivers, work in industries. And what our postulation probably, the pollution, air pollution is one of the important risk factors, because these microns, 0.1 micrometers or 2.5 particle matters, they go into the lungs and probably inflammation occurs there. Some minor particles can enter the circulation. It can precipitate atherosclerosis and cause inflammation and cause atherosclerotic plaques and myocardial infarction. And we have studied, actually, WHO has shown that 7 million people are having premature cardiovascular death due to pollution. 7 million people in the world. In fact, in India, 1.6 million people are dying because of pollution. In China, 1.3 million people. Pollution. In fact, Robert Koch is the cholera vaccine founder. He told in 1910 only, we have to fight fiercely pollution as one of the risk factors for cardiovascular events, like we fought for cholera and other pest control diseases. It is going to be true, because people who are genetically predisposed, there may be susceptible genes, then environmental factors may play for precipitating atherosclerotic heart disease. And there it is proved actually in various studies, there is increase in pollution, maybe by 5 microns to 10 microns per cubic meter, increase the incidence of cardiovascular events by 5 to 7%. The increased incidence of hypertension, acute cardiovascular events, stroke, arrhythmias, and heart failure.
So the hereditary or the genetics part also has.
The environment acts on the genetic factors. Both are.
So both are related to each other. So India at this moment we have a problem with both the environment, the diet, and also the.
I think top 10 cities in the world are highly polluted in India. Indian cities are there, I think, out of 20 cities.
Okay, I think the smaller cities will be, they will have less heart attack because of the less pollution over there.
Another lot of studies are there on genetics. Twins, monogenetic twins, and families with coronary artery disease. They are more prone for 5 to 7 times more prone for cardiovascular events. And another important factor is maternal. When maternal exposure to pollution, toxins, drugs, when the child are more prone for premature coronary artery disease, they are more prone for diabetes. That's also going to be a big problem.
Malnutrition in
the pregnancy, gestational, they are more prone for premature coronary artery disease, more prone for diabetes.
Thank you, Dr. Raghu. I think we have some very important inputs from you. Definitely we'll take it up more in the panel discussion. And thank you.
Thank you.
Next, I would like to introduce to you who is an eminent cardiologist of Bangalore. He is a senior consultant cardiologist in NH Narayan Institute of Cardiac Sciences. He is Dr.G.G Shetty. We'll see an introduction video and also a message from him. Then we'll have a discussion with him regarding one of the issues. So let's see the video on him.
Arise, awake, and do not stop until the goal is reached is quoted aptly by Swami Vivekananda for people who want to create difference in lives of people around them. Presenting to you a journey of a doctor who has travelled globally for conferences because he firmly believes that learning is a continuous process till you reach your goal. He is an avid thinker, researcher, clinician, and above all, an excellent organizer, which makes him stand out from the crowd. He is practicing cardiology since 1990 and had been trained in cardiology from some of the prestigious institutes of India like Nizam's Institute of Medical Sciences, Hyderabad, Banaras Hindu University, Varanasi, and GB Pant Hospital, New Delhi. Meet Dr.G.G Shetty, who has performed over 6,000 cath lab procedures till date and holds their specialization in performing coronary and peripheral angioplasty, balloon valvuloplasty, and pacemaker implantation. Currently, his area of focus is doing cath lab procedures. Through radial approach and via radial route, he has done more than 500 cath lab procedures till now. Dr. G.G. Shetty is a seasoned cardiologist and is currently working as Senior Consultant Cardiologist at Narayana Hrudayalaya Institute of Cardiac Sciences, Hosur Road, Bangalore. Dr. Shetty pursued his MBBS from Karnataka Medical College at Hubli in 1985 and MD in General Medicine from MR Medical College, Gulbarga in 1988. In his pursuit of knowledge, Dr. Shetty completed 2 years and 7 months training as senior resident in the Department of Cardiology of Nizam's Institute of Medical Sciences for the degree of Diploma of National Board Cardiology, which was awarded by the National Board of Examination, New Delhi, post which he did his DM in Cardiology from Institute of Medical Sciences, Varanasi in 1995. He also underwent a 3-month training course in cardiac cath lab and color Doppler echocardiography at GB Pant Hospital, New Delhi. Dr. Shetty was awarded with Fellowship of Indian College of Cardiology in the year 2000 and Fellowship of Cardiological Society of India in the year 2006. Dr. Shetty is committed to continued medical education and contributes regularly by giving lectures and participated in seminars. He has been the examiner for DM Cardiology course since the year 2007. Dr. G.G. Shetty is associated with many esteemed medical bodies of India. He was also an executive committee member of various medical associations like CSI Bangalore Chapter, CSI Karnataka Chapter, Indian College of Cardiology. Dr. G.G. Shetty was Secretary of CSI Bangalore Chapter for the year 2005 and 6 and Honorary Joint Secretary of CSI Karnataka Chapter for the year 2006-7. He is life member of various governing medical bodies like life member of API Bangalore Chapter since 1988, life member of API Central Body since 1989, life member of Medical Education Research Trust since 1990, life member of CSI Central Body since 1992, life member of Indian College of Cardiology since 1995, life member of CSI Karnataka Chapter since 2002, life member of Indian Academy of Echocardiography since 2004. Dr. Shetty has worked with some reputed colleges in Karnataka such as JSS Medical College, JN Medical College and St. John's Medical College Hospital at various designations such as lecturer, an assistant professor, an associate professor and professor. As a senior resident, he spent some time with Nizam's Institute of Medical Sciences and IMS BHU Varanasi. He was also associated with Belhol Apollo Hospital, Dubai, UAE as specialist cardiologist. Dr. G.G. Shetty is highly active in the field of clinical research since 1998 and has worked as a principal investigator in numerous trials. He has more than 30 publications in the national and international journals to his credit. To name a few are Management of Patient with Mechanical Prosthetic Heart Valve, published in Indian College of Cardiology, and Transcatheter Closure of Aorta Pulmonary Window using Implanzer device, published in Journal of Catheter and Cardiovascular Intervention. Dr. G.G. Shetty is recipient of numerous awards and accolades. In fact, during his tenure as Secretary of the Bangalore branch of Cardiological Society of India during 2006 and 7, the branch received the Best Branch Award, which is testimony of his excellent organizational skills. Dr. G.G. Shetty, apart from being in the forefront of medical field, is also working closely with needy and poor people so that they get quality cardiac care, for which he has organized free heart checkup camps covering overall health, ECG, blood sugar and cholesterol, etc. at various locations across the country like Sagar, Haveri, Bangalore and Gubbi. Let's listen to Healthy Heart Message from Dr.G.G Shetty.
All of us know that we need to exercise regularly, and probably most of us are willing to do that also. The problem is time crunch. How to make time for doing a regular exercise. I think we should take a clue from our marketing people. Multitasking is needs to be done here also. Making exclusive time for only exercising becomes difficult. So we can combine entertainment and exercise. So we, instead of sitting and watching the TV in a couch, I would rather suggest that you have your exercise equipments in front of the TV and utilize this particular time for your entertainment, watching the TV, as well as for exercise. So make it compulsory for yourself to do this. Whenever you are watching the TV, you can do either a treadmill or a bicycle like this, or do your free hand exercises. And this can go a long way in your regular exercising yourself.
Welcome, Dr. Shetty.
Thank you.
This is something new we saw today, that exercising and entertainment can go together. So when we probably watch the next World Cup or a cricket match, probably we can do some exercises in between.
Prolonged exercise.
Yes. We have a very important question for you is that, see, we have lots of heart attacks which are happening.
Yeah.
But is this something we can do as a treatment immediately to save the life of the patient?
Yes. The answer is yes. The immediate treatment which we give for patients with heart attacks, Dr. Muralidhara has already stressed upon the golden period with the first 6 hours. You have two options. The clot which is sitting inside the artery can be bursted with medicines which are called as clot-lysing medications, streptokinase, urokinase, TPA, and now tenecteplase, which is being produced in India now, which is quite a encouraging thing to know that the cost can come down. The use of these medications, which are quite expensive, which were imported before, are now being produced in India. So they can burst this clot and open up the arteries. One, this is with medications. The second one is with primary PTCA. As soon as you get into the hospital, you know that you have a heart attack. Instead of waiting to do anything else, directly take them to the cath lab, identify the block, and open it up with balloons and stents. Here we get almost instantaneous opening of the artery within about 20 minutes to 30 minutes, which can be achieved. The crux is nearing 80% of the facilities in India do not have this facility for primary PTCA. Only a few tertiary hospitals can provide this, and giving round-the-clock coverage, providing expert people who can do it safely is the issue. So where you cannot give this treatment of primary PTCA within a stipulated time, you can't, a person who comes with a heart attack in the night, you can't ask him to wait till the morning. So we have to do it immediately, and you need to have people who can do it safely. These are the two issues with primary PTCA. The second thing is tenecteplase, which is easily available medication, which I said is being now produced in India, and I hope the cost of these medications will also come down in the near future, can be used extensively to treat these patients.
So I have an important question attached to that. In India, a lot of these facilities are in the center of the city or in the big cities. And sometimes the patients are transferred by ambulance from these peripheral cities, and they come to the big hospitals and they don't have all the facilities over there. So during the transit time, which can be 2 hours, 3 hours, because you said the golden hour time, so do we have enough facilities for thrombolysis over there?
That's another option. See, the opening up of the artery is going to be delayed by more than 90 minutes. There's no point trying to wait for the artery to be opened by this method. Instead, what we can do is thrombolize them first, then transfer them to a place where further treatment can be done.
Okay, so we have another part of the question is that, so to prevent a heart attack, do we have enough medicines today? Like if somebody has high cholesterol, we say it's a risk factor, taking a statin, can it prevent a heart attack? Or say aspirin, people take over-the-counter medications sometimes, like aspirin is very common. So is it possible they can prevent?
We have enough and more medications to prevent heart attacks. Plenty of them. We have got aspirin, which can reduce the chances of getting a heart attack by about 15 to 20%. Then we have statins, which given properly can reduce the chances of heart attack by about 25%. Combinedly, aspirin plus statins, which are easily available even in the remote places, can be used to reduce the chances of getting a heart attack. See, Dr. Muralidhara also pointed out, it is not that this disease comes up just like that suddenly. It's like the first time you're on the engine of your car, the smoke starts depositing in your silencer. Similarly, the coronary arteries, the deposition is a slow process. It starts very young. By the age of about 20, it starts up. So what is important, if you are very serious about the prevention aspect of it, catch them young. Get your first lipid profile done at a very early age, about 20, and make them aware, say, look, you have a problem here, better correct it. Otherwise, you're going to have consequences later in life. And they are receptive at that particular age. They have the ability to exercise also. So advise them, and also we need to set an example by doing it ourselves before we tell to this young generation. Otherwise, they can be quite or not easy to convince them to do what they are supposed to do.
Thank you, Dr. Shetty. Actually, I was supposed to ask you only one question. I've asked you 3 questions. So thank you very much. We'll take more questions during the panel discussion we'll have after a while. Thank you very much, Dr. Shetty.
Thank you.
Thanks
nice
for
talking to you.
So we have come to the end of the first part of the program. So we'll come to the next part, which is the panel discussion in a while. Give us a few minutes back, we'll be back. So stay tuned in the meantime.
When it's about keeping your heart healthy, don't be careless. Know what's right to keep your heart healthy. From India's renowned heart specialists, Dr. V.S. Prakash, Dr. B G Muralidhara, Dr. Kiron Varghese, Dr.T.R Raghu and Dr.G.G Shetty. Log on to Facebook page Dil Se Dil Tak Healthy Heart on 27 July, Saturday from 7 p.m. onwards.
When it's about keeping your heart healthy, don't be careless. Know what is right to keep your heart healthy from India's renowned heart specialists, Dr. V.S. Prakash, Dr. B G Muralidhara, Dr. Kiron Varghese, Dr.T.R Raghu and Dr.G.G Shetty. Log on to Facebook page Dil Se Dil Tak Healthy Heart on 27 July, Saturday at 7 p.m. onwards.
ನಿಮ್ಮ ಹೃದಯವನ್ನ ಆರೋಗ್ಯಕರವಾಗಿಡೋ ವಿಷಯದಲ್ಲಿ ನಿರ್ಲಕ್ಷ್ಯ ಮಾಡದಿರಿ. ಭಾರತದ ರಿನೌಂಡ್ ಹಾರ್ಟ್ ಸ್ಪೆಷಲಿಸ್ಟ್ ಡಾಕ್ಟರ್ ವಿ.ಎಸ್. ಪ್ರಕಾಶ್, ಡಾಕ್ಟರ್ B G Muralidhara, ಡಾಕ್ಟರ್ ಕಿರಣ್ ವರ್ಗೀಸ್, Dr.T.R Raghu ಹಾಗೂ Dr.G.G Shetty ಅವರಿಂದ ನಿಮ್ಮ ಹೃದಯವನ್ನ ಆರೋಗ್ಯಕರವಾಗಿಡುವ ಸರಿಯಾದ ರೀತಿಯನ್ನ ತಿಳಿದುಕೊಳ್ಳಲು ಜುಲೈ 27 ಶನಿವಾರ ಸಂಜೆ 7ಕ್ಕೆ ದಿಲ್ ಸೆ ದಿಲ್ ತಕ್ ಹೆಲ್ದಿ ಹಾರ್ಟ್ ಫೇಸ್ಬುಕ್ ಪೇಜ್ಗೆ ಲಾಗ್ ಆನ್ ಆಗಿ.
Welcome back, Dil Se Dil Tak. Now we'll have an interesting phase, which is the panel expert with all the 5 experts today. The first question is for Dr. Prakash. It's a very important question. I keep asking this question to everybody whenever I meet an eminent cardiologist, because this is a very important part of the entire management of cardiovascular disease. Is that, can we actually diagnose an impending heart attack before actually it happens, like a preemption, by doing tests? Because nowadays we have a lot of very good advanced radiological tests which are available. So CT angiography, CT calcium scoring, stress test, does this shed any light that this person is going to have a heart attack in the next 6 months to 1 year?
Yeah, that's a very pertinent question. See, the most important thing is there are an array of tests available today. But the clinician needs to decide which one he would want to use to make a diagnosis, or rather preempt and make a diagnosis that is likely to have a heart issue in the future. So we have the pretest probabilities we'll have to look at. Low risk, intermediate risk, and high risk. So once you've clinically categorized what category the patient comes into, then accordingly you need to select your tests. Each test has its own limitations, its advantages and disadvantages. Barring a coronary angiography, which is gold standard, but that also has its limitations. Let's start with the least invasive, the most friendly test that you can do, a stress ECG. A stress ECG is a very simple test. You make the patient walk and then you stress the heart and ECG starts showing changes. This again depends on the pretest probability. If the pretest probability is low to intermediate, there could be a lot of false negatives as also false positives, but it has its limitations and advantages. Pretest possibility being high, it tends to the positive predictive value or the sensitivity specificity starts rising. So that's the advantage or disadvantage of a stress ECG. Let's look at calcium score. Calcium score again you have to again categorize pre-test whether high or, if the patient is a low to intermediate probability for coronary artery disease, his risk is low, you have a calcium score which is 0. It has a solid negative predictive value. Once your calcium score is 0 and you have a low to intermediate, you can more or less rule out coronary artery disease in that patient. But if he's a high risk, then if the calcium score is 0, you still can't exclude coronary artery disease in him. And in the young, you may not see calcium. You may have a plaque which would be ready, a soft plaque which can just rupture and end up with a heart attack. So again, predictive value in that subset of patients, the young, it has its limitations. That is when you probably move on to the next little invasive test, which is a CT coronary. CT coronary again, the same thing. Intermediate, low versus high risk. Again, intermediate to low, if the CT coronary is normal. CT coronary again, the negative predictive value is very high. In that subset of patients, the CT coronary is normal, you can just send him from the emergency room back home, saying that you are very unlikely to have a cardiac problem or a heart attack in the future. Whereas high probability, yes, CT coronary has its advantages. It definitely brings in the diagnosis. The sensitivity is very high. Specificity, it has its limitations. And again, if the calcium score is very high, CT coronary cannot read through the calcium. If a patient has undergone a stent, CT coronary again cannot read through the stents. So these are the limitations with even these tests. But that's what I would probably say: low, intermediate, and high. Based on that, you can categorize these tests and likewise choose which would be the one that would give you enough information about the future of your patient.
So in the future, as we see, we are going towards a very strong economy, developed economy. So money is not a problem. In the future, it will be lesser of a problem. More will be the propensity of developing more heart disease. Can this test become a part of a community outreach in the future?
Yes, somebody coming into the ER and then you do your CT coronary, I think that gives you reasonable information about ruling out coronary artery disease. Somebody comes with chest pain and you want to be sure. You do a troponin. Troponin is negative. You do a repeated troponin 3 hours. It's negative. You're more or less kind of sure that he doesn't have an acute coronary. But you want to be sure whether he has coronary artery disease and how to medicate him. CT coronary probably would guide you. And we also have something known as an FFR CT coronary, which should add information, which should add much more information. See, this is all anatomical. That is giving you physiological information. So that kind of adds information to this. And definitely I think today CT coronary has reached that level where the positive predictive value could be very high. But you have to start with looking at your patient, low, intermediate or high. So that is how likewise the accuracy of these tests start climbing.
Thank you, Dr. Prakash. Next question we have for Dr. Muralidhara. There's a myth that the patient who does angiography will have to undergo angioplasty in the future. So is it so, or I mean, one precedes the other or one leads to other?
No, this is a very common myth. A lot of people think that you do an angiogram and then he gets an angioplasty done, he gets a stent put in. This is not true at all. If you look at the statistics anywhere in the world, even including India, in any hospital, if you do 10 angiograms, probably 1, 2 or 3 only will end up with a stenting and angioplasty. 7 out of 10 do not get an angioplasty done. So it's probably about 3 out of 10 or 2 out of 10. So it does not mean that everybody who goes for an angiogram gets an angioplasty. The only situation where they go for an angiogram and angioplasty in the same setting is what Dr.G.G Shetty earlier did. When we are doing a primary angioplasty, somebody comes with a heart attack and he has a blockage, we do an angiogram and we find a blockage, we almost always recommend angioplasty in the same sitting. That is called primary angioplasty. But for that, in the other sitting, they always have the option to come back and take a call. It doesn't have to be necessarily done. So that's a very common myth. Unless the patient has a heart attack, angioplasty and angiogram do not have to be done in the same sitting. And also these are two different things. Angiography and angioplasty are two different things. People also have confusion about that. People need to understand that angiography is a test performed to identify whether you have a blockage or not, whether you have suffered from a heart attack or not. Whether the angioplasty is a treatment procedure done to clear these blockages. And in the angioplasty procedure, most often these days, almost invariably, we end up using a stent. Again, there is a confusion. People think angioplasty is different and stenting is different. No. Angioplasty and stenting are two parts of the same procedure. It is like first innings and second innings. If we identify a blockage, we use a balloon to dilate it. That is called angioplasty. That is followed by stent implantation. That means a piece of metal tube goes along with the balloon and that gets implanted in the heart. So angioplasty and stenting are part of the same procedure, whereas angiography is only a test. And not necessarily every patient who gets an angiogram gets an angioplasty. That is a real myth.
But leaving aside the primary angioplasties, if there's a situation like a patient having dyslipidemia, having occasional chest pains, we do an angiogram and then finding a block which needs an angioplasty in the future. Do we wait for the next patient to come back or we do it then and there?
See, as Dr. Prakash put it, if the patient has got no symptoms, he only has risk factors, absolutely no symptoms. There we are doing an angiogram only for risk profiling. In that case, probably a CT angiogram would suffice. We don't have to do necessarily a conventional angiogram. A conventional angiogram is done only when we think that his pre-test probability of having a block is very high, his chances of requiring a stent are also pretty high. If we think he's a lower or intermediate risk and he has only risk factors, probably I would recommend only a CT angiogram, not a conventional angiogram at all. If we do a conventional angiogram with a physiological evidence saying that he has a stress test which is positive, he has got a stress echo which is positive, and then I do an angiogram and I find a significant block, critical block in the proximal coronary arteries, probably we are justified in doing angioplasty in that setting.
Thanks. So next question is for Dr. Varghese. A very important question is that when a patient goes with a chest pain, having a heart attack or doesn't have a heart attack with a chest pain, repeated chest pain, diabetic patient, sometimes the doctor decides to do angioplasty, sometimes they do a CABG or a bypass. And the patient sometimes comes up with a complaint that we could be, because angioplasty is so popular, that we could have done a balloon angioplasty. Why we need a CABG in that patient? So how do you differentiate which patients to choose for our angioplasty and which for a CABG or a bypass?
Clearly, there are many different parameters to be evaluated before one takes that decision. But like Dr. Muralidhara said, if a patient has come with chest pain and is actually having an active heart attack or what you call a STEMI, then there's no decision. I mean, just go ahead and open up the culprit artery. That means whichever block, he may be having multiple blocks, but whichever block is causing the heart attack, that should be opened up then and there. I don't think there's much debate about that, and that's the universal practice. I think your question is more applicable to a person who is stable, who's just undergone an angiogram, whether he has angina or not, whether he has most probably an abnormal stress test, and that's why the angiogram has been done, and this has shown some blocks. And judging from your question, I think the question is, why wasn't angioplasty done rather than why was surgery done?
Yes.
So there are certain blocks for which angioplasty gives superior results, and there are some for which bypass surgery. Traditionally, patients who had a block in the left main coronary artery, that means the left-sided artery starts as a single stem and then branches into two. So that is called the left main, and often the disease involves the bifurcation. That and chronic total occlusions, that means totally blockage vessels which has been blocked for more than 3 months. Such vessels are traditionally difficult to do with angioplasty. However, a lot of technology has advanced nowadays, and nowadays we are commonly doing left main angioplasties and even chronic total occlusions. Yet, there are certain instances where we feel that surgery gives better results. Clearly, those with multiple blocks and diabetes. Long-term results seem to be better with bypass surgery. So even though the patient obviously would favor quick angioplasty, we need to convince them that surgery is a better option in view of long-term results. Again, there are patients who have a lot of diffuse disease, heavily calcified. Many of these are not amenable for angioplasty. We can do rotablation, where we do it once in a while to remove the calcium, but sometimes the disease is just too extensive, it's not worth it. You need multiple stents, very complex procedure, whereas surgery can relatively easily be done if the distal vessel is good. Similarly, Indians commonly have small vessels with diffuse disease. The smallest stent which is commonly used is 2.5 millimeters in diameter, and many of the patients have blocks in vessels which are 1.5, 2 millimeters in diameter, which is too small to put in a stent, and yet a good surgeon can easily graft them. So there are definite instances where we find that a good surgical procedure, CABG, gives better long-term results. However, even in such instances, if the patient is very frail or has bad lungs or a very weak heart, then they may not be able to withstand the surgery. So even though the first choice would be bypass surgery, we do offer angioplasty, and we do that once in a while. We may not do every single block, but at least to improve matters. So the decision really has to take into account many factors, and I think the cardiologist is best suited for that. And my message to the public is, leave the decision to the cardiologist. He definitely wants to do angioplasty, and yet if he says bypass surgery, accept that and please go ahead.
So this is a very important message. We should leave the Google doctor and listen to the actual doctor. So this the public should drive home the message from today. So next question is for Dr. Raghu. This question is very important because people are having more of heart attacks within their working life, 45, 40, 50. And there is a reason for returning to work. So sometimes they are in important positions, they are holding important posts. So what is the time, minimum time, which they leave for rehabilitation after a heart attack, after a stent or say bypass. How sooner can they return, and what are the factors which depend on that?
See, cardiac rehabilitation is an integral part of management of heart patients. Because that is all, probably in India, cardiac rehabilitation is not developed. But Europe and US, it's part of Medicare. Because after an acute myocardial infarction, after angioplasty, after bypass surgery, Medicare pays for the rehabilitation of those patients. It may take for 30 days or 2 months, Medicare pays. But in India, that is not developed. That is more important because after an heart attack, a lot of patient becomes psychologically depressive, sometimes anxiety. We have to deal with psychosocial aspects. Before going to that, probably a lot of patients after angioplasty, they think they have gone to a major problem, they may not survive. And bypass, all these patients have, first aspect you have to deal with psychosocial. Then rehabilitation. Rehabilitation is important component because it depends on the severity of the heart problem. If patient has got a minor problem, he has got one single vessel block, heart function is normal, he has stented, or he had a mild heart attack, heart function is preserved. Probably 2 to 3 weeks rest, he can go back to his normal. Usually, once he goes to a second visit, probably cardiologist will assess his cardiac status, he will do a stress test, he will do an echocardiogram, there is no abnormality, he can do his normal exercise capacity, then always they can go back to their work. Only problem when they have got a massive myocardial infarction, heart is damaged, heart function is weak, probably it takes long time to recovery. If they undergo bypass or angioplasty, still they have to take at least 4 to 6 weeks of rest, then again reassessed by the primary physician or a cardiologist, they have to do an echo, they have to do a, probably if they have got ectopic, they have to do Holter, they have to do a limited exercise state. Depending upon the exercise capacity, we can advise them to start doing their activities, probably increase their activity over a period of time. Probably it may take 3 months, 4 months, especially bypass surgery because wound healing itself will take some time. So most of these patients, they can go back to their normal work after surgery or angioplasty or after management of acute myocardial infarction. Another important aspect is sexual counseling is also important. Most of these patients are afraid of, after weeks or months of an heart attack, after an angioplasty or surgery, they are afraid of having sex. And that's also then their partner will come and tell this is the problem. They are also afraid. And these things should be discussed with the patient, with the family as a part of the cardiac rehabilitation and tell them these are the things. Probably if they can able to do moderate activity, they can have their normal sexual life. Another important aspect, when you are doing rehabilitation, you are also dealing with the lifestyle management. You are going to reduce the risk factors. You are going to have, they have always, healthy diet is also part of the rehabilitation. Are going to reduce the risk and it is going to reduce the mortality, morbidity, increase the longevity of the patients with heart attack and angioplasty and bypass surgery.
And does the type of work also dictate when they can, because some people are manual laborers, maybe, cricketers or footballers, let's come to the sports part. If the young people, they also have heart attack. So is it, can they also return to the active sports?
It depends on the severity of the heart attack. Yeah. If it is a mild heart attack, they can go back to their work. Because we do a lot of KSRTC drivers, a lot of auto drivers, they go back to their work. Only thing because security, probably pilots, if they have got a heart attack, if they are mild heart, he cannot pilot this one. There is some eye sensitive this one. When you risk to the population is more, then you have to avoid. If you got a minimal heart disease also, they will be.
Thank you, Dr. Raghu. Next, we'll come to Dr. Shetty. Recently, Donald Trump says that kidney is at the heart. So, recently, this comment has come up. So, we'll start with that. So, there are problems like kidney disease, say hypertension, or dyslipidemia. Is heart attack more common in this type of patients, especially kidney disease? What do you think?
A simple answer is yes. Risk factors, you're basically asking me about the risk factors. Risk factors can basically classified into 2 types. One is modifiable risk factors and non-modifiable risk factors. Let me start with the non-modifiable risk factors. A family history. What can you do about it? You're born to your parents. So you can't change your genes now, you can't change your parents. So you have to live with what we have. A family history of heart attack. See, recently the latest journal of Indian Heart Journal has come out with an editorial emphasizing the importance of a test called as LP little a. This is called as the deadly cholesterol. Levels more than 50 are considered as a marker of a rapidly progressing atherosclerosis within the coronary artery disease, predisposing them to early heart attacks. So family history. You have already stressed upon blood pressure. Then we have sugar or diabetes. Third is cholesterol. Fourth, very important one is smoking. Fifth, excess body weight. With we measure what is called as the waist-hip ratio. If we have got a bigger tummy or a waist-hip ratio, people who have a bigger waist-hip ratio are more prone for coronary artery disease. Inactivity, 10,000 steps per day. If you're not doing it, there again you are exposed to the heart problems. And then we have got a few other type A personality. If you are a high achiever and the way you respond to a problem decides how much of adrenaline you pump into your system, which can enhance atherosclerosis. There are many substances which can be pumped into the body, which can be controlled by your behavior, reducing the blood pressure and reducing the risk of atherosclerosis within your body. So type A personality is the other one. And certain other substances called as hyperhomocystinemia. These are the other ones. We have got a beautiful study which was done, and St. John's was the center of this particular study called as the Interheart study, which came from India, which has emphasized and clearly told there are 9 important risk factors which predispose us to the development of heart disease, which I have just now enumerated.
Yes, so if you see nowadays, I mean, a lot of diagnostic tests are available, and you said LP little a. So apolipoprotein is also there. There are other markers. So along with the LDL, generally the doctors, they suggest doing an LDL level, lipid levels, sugar levels, then creatinine levels. So can we add this to the tests as well? Does it help?
Yes, it does help. We need to have a regular test. I was just emphasizing we need to do this test early in life so that a person who is prone for it knows that he has this problem. Dyslipidemia is a problem which we need to do this test at the age of 20. LDL more than 130 or more than 160, they need to treat them. And then LP little a, which also can be done, and say that, see, look, genetically you are a high person, you are at a higher risk of developing the coronary artery disease. So yes, these tests need to be done early, and then do a instead of just doing a simple blood sugar, do a HbA1c.
Okay.
I have many instances where sugars have been done, found to be normal, and you do a HbA1c, it is more than 6, 7, 8, and some of the people who come with heart attacks, I have seen them, they say, I'm not a diabetic, and their HbA1c will be somewhere around 9, 10, 11. Okay. So they miss out this particular. So it's important to have a regular checkup from a very early age. If you want the long-term results, start it early.
So how important is the kidney? If somebody has stage 3 or something like that, is he more prone to a heart attack?
Yes. People with chronic kidney disease are at a higher risk of developing the atherosclerosis, not just in the coronary arteries, but in the entire body. In the brain, in the kidneys, in the peripheries. So they are more prone for developing. And most people with kidney disease, they die of heart attacks.
So we need to involve a nephrologist quite early in the management?
I wouldn't say unless there is an elevated serum creatinine or a drop in GFR. That's the stage at which I would ask the nephrologist to intervene. Before that, I can do it myself.
So again, during the first phase also I asked you 3 questions. Now I'll ask you the third question. So what about the gender bias? Females, we have heard that females don't develop heart attacks. They give heart attacks, but they themselves are secure. So what is your view on this?
Yeah, they give heart attacks when they're young. Yeah, they give heart attacks when they're young. Let me tell you this. Up to the age of about 45, when they are during the fertile period of life, God has also been partial to them. They don't develop these heart attacks. Later in life, once they develop menopause, in about 10 years, the risk of coronary artery disease in men and women is almost the same. So up to 45 they are protected. Next 10 years they catch up with the disease, and by about 55 the risk of heart attack both in men and women is almost the same. And then starts after 55, say for example a woman develops a heart attack, they fare badly. They got smaller vessels, smaller size vessels, and while recovering from the heart attack, the mortality as a result of heart attack in women is higher. So initially they are protected, later on they catch up, later in life they pay for it in a bigger way compared to men. I hope I answered your question.
So yes, life is a great leveler, that's we learned. So we should be careful about it. There's one question from my end, which is not there in the list, but I would like to ask all of you this question is that we are seeing new drugs in the treatment of, one of the complications of heart attack or heart disease is heart failure, commonest, and this is a big menace for us. And we can see anti-diabetic drugs being tried in that, like SGLT2. What's your view, individual view on that? I'll start with Dr. Prakash.
If you're specifically talking about SGLT2, yes, I think that's come in a big way. Next to metformin, I think metformin is the number one diabetic drug today, which is listed as an anti-aging drug. That's the unique thing about metformin. I think next to that, probably SGLT2 inhibitors have overtaken all the others, and they are next in the line. Insulin is way down. So SGLT2 inhibitors, all of them as a group, they have tried various trials with each one of them, dapagliflozin and even the others, have clearly shown their superiority in the terms of reducing heart failure and very safe in in reducing kidney issues in patients with diabetes and reducing cardiovascular risk and morbidity and all that. So I think SGLT2 inhibitors have really come a long way, and they are now listed as the number 2 in the list. Sulfonylureas are way down, and insulin probably somewhere in the vicinity, but definitely not in comparison. The higher risks of, especially the analogs, they have said, higher risk of cancer and those issues which are there with insulin, increased obesity, weight gain, those problems which are not seen with SGLT2 inhibitors. So that is what probably my comment on SGLT2 would be.
Have you used it in heart failure?
Yes. I normally, definitely start with metformin. Normally we have the endocrinologist take care of our diabetic patients, but whenever we are into prescribing diabetic drugs, the second line next to metformin is an SGLT2 inhibitor. And I find them very friendly. Very few patients have problems with SGLT2 inhibitors, and their tolerances are pretty good. Chances of hypoglycemia, all those are still much on the lower range in comparison with sulfonylureas. They're very friendly drugs.
Your view on it?
I'm in love with SGLT2 inhibitors. In fact, according to me, the best thing that has happened to the heart failure patients in the last 10 years, apart from ARNI inhibitors, is SGLT2 inhibitors. They are useful in patients with congestive heart failure, both with reduced heart function and with preserved ejection fraction. It's beautiful drugs. It will reduce the plasma volume without affecting the kidney flow, without affecting the renal parameters. Most of the cardiac patients we get, almost more than half of them have got diabetes. So I would entirely agree with Dr. Prakash. Today, according to me, at least as per the cardiologists are concerned, next to metformin, the drug that we use is SGLT2 inhibitors. We, in fact, as he said it, it's way ahead of even insulin. Insulin has got a lot of problems, very difficult to use in our country, and insulin is contraindicated in patients with heart failure. It does bad. They gain weight, the heart failure worsens. And most of our patients, when they come with myocardial infarction, in India they come with a delayed presentation. Invariably, a lot of them have got reduced ejection fraction. And in all of them, SGLT inhibitors have done wonders. They do extremely well. Though they said there are some complications with SGLT inhibitors, the most dreaded being the phoneus gangrene and then mycotic infections. At least, See, I have been using SGLT2 inhibitors for the last 4 years. I have at least more than 1,000 patients on SGLT2 inhibitors. I have not seen it, though my diabetologist colleagues claim that they have seen 1, 2. But when we are using in thousands of patients and we don't see a single mycotic infection, I think it's pretty rare. So most of the problem is in our patients, SGLT2 inhibitors, they do very well and they are tolerated extremely well. There are no risks of hypoglycemia. And most of the drugs can be used even in patients with mild to moderate renal dysfunction. And we have fantastic results with empagliflozin, Cana, and DAPO, all 3 of them, particularly in patients with established coronary artery disease, particularly with heart failure. I think these are wonderful drugs. They have helped us a lot in preventing heart failures and in preventing readmissions to the hospital, which is the biggest problem of the heart failure.
My take is different because all these EMPA-REG, CANVAS, declared they never studied heart failure patients. Only cardiovascular disease, they reduced heart failure hospitalization. There is no data for treating hospital. Only now EMPA reduce, EMPA preserve is studies going on. The data is expected in 2020. At present, as per the guidelines, there is no indication for treating heart failure. Only you should be careful because ARNI itself causes diuresis, natriuresis, and there is a fluid depletion. When you are giving diuretics, when you are giving ARNI, if you give SGLT inhibitors can cause problem, and patient you should be careful when you are giving. But as per the data, there is no treatment as indicated in heart failure. That is my take on that. You can use it as a control of diabetes, not for heart failure.
Well, FDA has recently come out with a clear guidelines saying that in patients with diabetes, with established coronary artery disease, empagliflozin is given as a cardioprotector. See, earlier the drugs were studied to see if they are causing any cardiovascular complications and increased mortality. But now it has come with a clear guidelines. FDA has clearly given a guideline saying that you should use empagliflozin in patients with diabetes, with established heart disease to prevent cardiovascular complications and to protect the heart. So there are 3 different trials, all of them are clearly shown. In patients with established coronary artery disease, in empagliflozin, empagliflozin trial and Cana, both EMPA-REG and this one, 60% of the patients and 70% of the patients in these 2 trials had established coronary artery disease, had heart failure, had MI. So it was a clearly secondary prevention trials, both of them. They are not primary prevention trials. In both these trials, it has clearly shown mortality benefit. There is no doubt about it. Only with declared TIMI-23, which is a primary prevention trial, where only 10% of the patients had got established heart disease, 80% did not have established heart disease. There it did not show mortality benefit. There it showed only heart failure benefit. As far as EMPA is concerned, heart failure is reduced, cardiovascular mortality is reduced, total mortality is also reduced, which is a very, very strong endpoint. In fact, recently we had Sanjay talking to us. I'm sure my friend also attended that program. He clearly said it is impossible to prove mortality benefit through these days when the patient is already on 8-6 standard therapies. When this was used in addition to the standard care of therapy, which is the standard as of now, when we add empagliflozin, there is a mortality benefit, which is a very hard endpoint, which is very difficult to prove. We have had very few drugs in the last 10 years which have come with a mortality benefit. So I don't think there is any doubt about using empagliflozin in patients with established heart failure. In fact, I would go and say that if you don't give empagliflozin today to a diabetic patient with established coronary artery disease, probably we are failing in our duty.
I will ask you, so if you have a scenario like that, somebody after a primary angioplasty having some sort of heart failure, having pre-loaded any ACE inhibitor plus your SGLT2, how will the results go?
So, are you talking about a diabetic patient or a non-diabetic? Actually, the issue is the patient diabetic or not? If the patient is diabetic, there is no question about it. The American Diabetes Association guidelines very clearly mentions that after metformin, the next drug should be empagliflozin, like he said, not just SGLT2, because that's the only drug which has very strongly shown a mortality benefit, not just cardiovascular mortality, but all kinds of mortality. We're not talking only of hospitalization for heart failure, where also there's a robust reduction. So there is no question about it. And now if you look at the American Heart Association recent guidelines on primary prevention, even they have said that in diabetics, after metformin, the second drug of choice, the
don't say that in heart disease. Any diabetes, that after performing the second drug should probably be an SGLT2 inhibitor. And I firmly believe that the only problem is the cost. So in the Indian context, not many of our patients can afford it, and sometimes we need to give a drug which they can afford rather than the best treatment, because they just stop it. So some treatment is clearly better than no treatment. No doubt about it, SGLT2 inhibitors are great drugs for diabetics with established cardiovascular disease, and definitely so if there is an element of heart failure. Now whether it should be used in a patient with heart failure who is non-diabetic, I think we need to await data on that. We have other drugs in the gardening which have also come out with the scene. We can use all that and await the results. Anyway, it should be off-label. I wouldn't say it is wrong because there is very encouraging data, but trials are ongoing for that.
And we have got a very important aspect of where actually endocrinology and cardiology might actually merge. This is very important. In the future program we can take up a separate actually discussion on this. So let's go to the point of cardiology. In fact, SGLTs are being used than diabetes. Diabetologists are still infatuated with glutens and they are still stuck to glutens, whereas we are completely moved on and we are to the SGLT inhibitors. As Dr. Kiron said, if you want to bring down the cost, you can use even half dose empagliflozin. That will also give a lot of mortality benefit. In fact, in many discussion, they say use half dose gluten, half dose empagliflozin if you want to bring down the cost, but don't deny the benefit of empagliflozin. Thanks. We'll take some questions from the audience and also online. We are around 20,000.
We have discussed. I think family history is one of the risk factors. Given that as doctors, you know your patients, can you do more by educating them to get their children lipid profiles down very early, and they can be monitored ongoing, which can reduce that risk factor? As they say, prevention is better than cure. So, as doctors, can you educate your patients to make sure their children are looked after early so that the risk, the percentage drops?
Yeah, definitely you can do it. More than the children. So once your brother gets a heart attack, your chance of getting a heart attack increases by 50% compared to the general population. So we advise, if there are 3 or 4 male members in the family and one gets a heart attack, others should get their lipid profile done straight away to see what it is. Coming to the issue of children, if they're over the age of 18 years, they need to have a lipid profile check done. And if the lipids are abnormal, they need to be treated. Not with medicines, primarily they need to be treated with lifestyle changes. The lifestyle changes can change the profile for a longer time. Only if it is resistant to lifestyle changes, there will be the question of drugs coming. The most important thing is, for family members of the heart attack patient is, get your lipids done, look at your risk profile and take, getting lifestyle changes which are important. Other thing is, in these patients, if they have got high incidence of heart attacks, like other had patients, I treated 2 years apart from the span of 3 months coming with heart attacks. Such people are extremely risk of coronary arteriosis. When you think the risk is high, the risk profile is high, family history is there, and they have high lipid profile, probably CT coronary angiogram is not out of place. It can identify the blockages very early. Even blockages which are missed by conventional angiogram can be identified. Smaller blockages can be identified. Critical blockages can be identified. Calcium scoring also is one of the independent risk factors that helps. So these patients with the high-risk family individuals, probably a CT coronary angiogram is definitely.
And Anantaramu, doctor was formally chief architect at ISRO. My question is, one is very interesting program and we will be very, very happy. I would like to welcome the panel of doctors to give an educative program for ISRO. I would like to invite from the Officers Association, that is one thing. And then, Okay, maybe I don't have any specific question here right now. But maybe our scientists would like to see how much we can get things get corrected, all those things. We could educate. Maybe some of the doctors can let you know it for one person at his own. Maybe we would like to give a talk. And I also would like to welcome all the doctors, ISRO Satellite Center at the Rocket Lab Complex, which we recently got Chandrayaan. And we're very happy to take you as a VIP delegate. Thank you. So, thank you very much. We should congratulate the program. I would welcome to all.
I think as doctors, it is our duty. Yes. None of us would be happy to come and give a talk to ISRO or to any other organization, because most of us, if you've noticed, are quite passionate about prevention and even free work. So free camps are being done by all of us. To come and give a talk in such a center would be our greatest pleasure.
Yeah, thank you. Just a note in specific cardiovascular diseases. Most of the developments which we are using, maybe the stents, maybe the ultrasounds, they have all been an offshoot of the space program, of the defense technology and the space program. There is a lot the space program can do for upbringing the technology generation
on a fast race compared to all you end a doctor sitting over there. Our daily work starts from 9 to 6, but to beat the traffic and Bangalore, potholes and other things, we have to do 1 hour early and 1 hour late. So we don't have daily train for taking care of our body. By the time we come back home, we'll be very tired. So weekends is long weekend. So can I do 1 hour of rigorous exercise in 1 day of a weekend and can still be healthy, or what changes for lifestyle you people suggest?
Let me tell you one thing. When you do somebody, I do 120 kg squats, 120 kg bench. Okay. That nobody will do. I'm not even recommending that. That when I really want to see, I'm passing the do it. I'm not still do it. Yesterday I started doing 20 kgs, 120 kgs, 8 to 10 repetitions, 4. My regular program. I'm ready to go out. But I'm just telling you, where is this again? I'm sure we can develop you can push your exercise to weekends. It has to be consistent 5 days a week, or at least 3 to 4 days a week. And then it depends on what kind of rigorous exercise that you're doing. Weekend exercise may not really want to doing regular exercise. But some people do jog, temporarily the weekends, and they're still able to make up, reduce their, risk, cardiac risk, and keep their risk factors down. It's all possible. But I still recommend probably, rather than pushing that to the weekend, why not be more consistent?
I do agree with, very much with this. See, some exercises clearly.
Somebody, I do 120 kg squats, 120 kg bench. Okay. That nobody will do. I'm not even recommending that. That when I really want to see, I'm passing the do it. I'm not still do it. Yesterday I started doing 20 kgs, 120 kgs, 8 to 10 repetitions, 4. My regular program. I'm ready to go out. But I'm just telling you, where is this again? I'm sure we can develop you can push your exercise to weekends. It has to be consistent 5 days a week, or at least 3 to 4 days a week. And then it depends on what kind of rigorous exercise that you're doing. Weekend exercises may not really want to doing regular exercise. But some people do jog, temporarily the weekends, and they're still able to make up, reduce their, risk, cardiac risk, and keep their risk factors down. It's all possible. But I still recommend probably, rather than pushing that to the weekend, why not be more consistent?
I do agree with, very much with this. See, some exercises clearly have time to exercise and stand patiently on the ground floor waiting for lift for 3 minutes. enough a lift to come, and they do not play on floor or 2 floors. I never use the elevators in the hospital, never, ever. And I manage about 20 floors every day during working, because I don't find time to go for exercise. But I do the activity. You can park your car 100 meters away from your normal slot. You can get down from the bus one stop earlier. You can, instead of telling us how to go and pick up the remote from the TV, go pick it up yourself. That also you want to do. I mean, this is what we find. Go and buy the groceries. No, you won't do that. You get somebody else to do it. It's just a few minutes. You can build activity. When I get a few minutes free, I sometimes just for no reason go down to the ground floor and come out. And I do it very purposefully, looking as if I'm going to see a patient. You could do the same. The American Diabetes Association has clearly said that you should not sit for more than half an hour at a time. Prolonged periods of sitting should be interrupted every half an hour with a brief period of exercise. That's what it says. However brief it is, just get up, pretend you're going to go to the toilet or going to get a cup of tea or water, or your colleague in the next cubicle, do something. Don't sit for prolonged periods. This is a major risk factor, and I'm sure with commitment, you don't need the kind of commitment. You can do it, everyone can do it.
Dr. Prakash actually reminds us of Virat Kohli. We see all those videos on So adding to that, I observed in offices also, people talking about extension. Same floor, they can even walk 10 steps. So the first thing should start in the office. People can actually walk, and instead of talking over phone, they can walk and discuss the matter.
No, that is not doing that. Yeah, the standing Dr. Shetty, I have a question for you. This comes from the online audience. From layman, what is the difference between cardiac arrest and heart attack? These are two layman terms, but what does it mean for you?
Cardiac arrest and heart attack. Yes. Heart attack is the common man's terminology used for myocardial infarction. The scientific name is myocardial infarction, and common man uses the word heart attack. There is a sudden cessation of the blood supply to a small portion of the heart when one of the arteries is blocked. The consequences of this are damage to the heart muscle. This is what is heart attack. Heart attack causes death. If, say, for example, 100 people develop a heart attack, roughly, with the present available technology, roughly about 4% will die even after primary angioplasty. Even after giving the best possible treatment in the hospital, there is a possibility of death to an extent of 4%. Before the onset, let me take you historically over time. In the early 1970s, when CC was not there, if 100 people developed heart attack, the mortality was about 30%. With the introduction of the coronary care units, it reduced about 15%. With the introduction of the thrombolytic agents, it reduced about 8%. With the introduction of primary PTC, it has reduced about 4%. So the treatment is evolved and has reduced. But in the golden hour, in the first few minutes, where they can develop most people don't reach the hospital because of the electrical problems which the patient can develop. And electrophysiologist here spoke about sudden cardiac death. That, unless you reach the hospital, you can't get the treatment. So these days, we see that in foreign countries, there are defibrillators which are available in the malls, and people are educated about how to use them and when to use them. So this can go a long way in reducing the mortality. So myocardial infarction is development, the process of blocking and consequences. And the other one is heart stopping. As a consequence of the insult to the heart stops working, that is cardiac arrest. And it may not be only heart attack. There are the final common thing that is going to happen to all people who die is the heart is going to stop. Cardiac arrest can occur irrespective of any cause. That's the final common.
In simple terms, heart attack is myocardial infarction. Cardiac arrest is a complication of myocardial infarction. Heart attack, people can be saved. Cardiac arrest, very few people can be saved. And cardiac arrest occurs because of many reasons, not just a heart attack. There are many reasons which lead to a cardiac arrest. And cardiac arrest is the ultimate thing. As Dr. Shetty put it, that's the final way the person will the heart just stops. So you really can't do much at that time. But for heart attack, we have definitely so many treatment options available. So people need to understand that heart attack can be treated, cardiac arrest is probably cannot be treated.
I have a very funny question on this. Are you seeing a Dr. Shetty? I have a question for you. This comes from the online audience. We have heard from them. What is the difference between cardiac arrest and heart attack? These are two layman terms, but what does it mean for you?
Cardiac arrest and heart attack. Yes. Heart attack is the common man's terminology used for myocardial infarction. The scientific name is myocardial infarction, and common man uses the word heart attack. There is a sudden cessation of the blood supply to a small portion of the heart when one of the arteries is blocked. The consequences of this are damage to the heart muscle. This is what is heart attack. Heart attack causes death. If, say, for example, 100 people develop a heart attack, roughly, with the present available technology, roughly about 4% will die even after primary angioplasty. Even after giving the best possible treatment in the hospital, there is a possibility of death to an extent of 4%. Before onset, let me take you historically over time. In the early 1970s, when CC was not there, if 100 people developed heart attack, the mortality was about 30%. With the introduction of the coronary care units, it reduced about 15%. With the introduction of the thrombolytic agents, it reduced about 8%. With the introduction of primary PTC, it has reduced about 4%. So the treatment is evolved and has reduced. But in the golden hour, in the first few minutes, where they can develop most people don't reach the hospital because of the electrical problems which the patient can develop. And electrophysiologist here spoke about the sudden cardiac death. That, unless you reach the hospital, you can't do the treatment. So these days we see that in foreign countries there are defibrillators which are available in the malls, and people are educated about how to use them and when to use them. So this can go a long way in reducing the mortality. So myocardial infarction is development, the process of blocking and consequences, and the other one is heart stopping. As a consequence of the insult to the heart stops working, that is cardiac arrest. And it may not be only heart attack. There are the final common thing that is going to happen to all people who die is the heart is going to stop. Cardiac arrest can occur irrespective of any cause. That's the final common.
In simple terms, heart attack is myocardial infarction. Cardiac arrest is a complication of myocardial infarction. Heart attack people can be saved. Cardiac arrest, very few people can be saved. And cardiac arrest occurs because of many reasons, not just a heart attack. There are many reasons which lead to a cardiac arrest. And cardiac arrest is the ultimate thing. As Dr. Shetty put it, that's the final way the person will the heart just stops. So you really can't do much at that time. But for heart attack, we have definitely so many treatment options available. So people need to understand that heart attack can be treated, cardiac arrest is probably cannot be treated.
I have a very funny question on this. Are you seeing a Dr. Shetty? I have a question for you. This comes from the online audience. We have heard from them. What is the difference between cardiac arrest and heart attack? These are two layman terms, but what does it mean for you?
Cardiac arrest and heart attack. Yes. Heart attack is the common man's terminology used for myocardial infarction. The scientific name is myocardial infarction, and common man uses the word heart attack. There is a sudden cessation of the blood supply to a small portion of the heart when one of the arteries is blocked. The consequences of this are damage to the heart muscle. This is what is heart attack. Heart attack causes death. If, say, for example, 100 people develop a heart attack, roughly, with the present available technology, roughly about 4% will die even after primary angioplasty. Even after giving the best possible treatment in the hospital, there is a possibility of death to an extent of 4%. Before onset, let me take you historically over time. In the early 1970s, when CC was not there, if 100 people developed heart attack, the mortality was about 30%. with the introduction of the coronary care units, it reduced about 15%. With the introduction of the thrombolytic agents, it reduced about 8%. With the introduction of primary PTC, it has reduced about 4%. So the treatment is evolved and has reduced. But in the golden hour, in the first few minutes, where they can develop most people don't reach the hospital because of the electrical problems which the patient can develop. And electrophysiologist here spoke about sudden cardiac death. That, unless you reach the hospital, you can't get the treatment. So these days, we see that in foreign countries, there are defibrillators which are available in the malls, and people are educated about how to use them and when to use them. So this can go a long way in reducing the mortality. So myocardial infarction is development, the process of clotting and consequences, and the other one is heart stopping. As a consequence of the insult to the heart stops working, that is cardiac arrest. And it may not be only heart attack. There are final common thing that is going to happen to all people who die is the heart is going to stop. Cardiac arrest can occur irrespective of any cause. That's the final common.
In simple terms, heart attack is myocardial infarction. Cardiac arrest is a complication of myocardial infarction. Heart attack people can be saved. Cardiac arrest, very few people can be saved. And cardiac arrest occurs because of many reasons, not just a heart attack. There are many reasons which lead to a cardiac arrest. And cardiac arrest is the ultimate thing. As Dr. Shetty put it, that's the final way the person is. The heart just stops. So you really can't do much at that time. But for heart attack, we have definitely so many treatment options available. So people need to understand that heart attack can be treated, cardiac arrest is probably cannot be treated.
I have a very funny question on this. Are we seeing a
No. It has not happened here in the West, no. So I don't think it is going to happen in India. Mainly because, first of all, our awareness levels are still very, very, very low. We have to mention. People do not. See, we have simple devices like glucose monitoring device, blood pressure monitoring devices, and even those are not being commonly used for most of our patients, though we suggest and recommend it. So I do not see that I think AEDs are going to be kept at home at least. The more I would like to see at least AEDs being available in public transport systems, public places like malls and railway stations and airports, and people being taught about it, people being made aware about it. Most of the people do not have idea about your basic life support, BLS or any kind of training is not there. So I think that needs to happen first before we start talking about AEDs in the kitchens and bedrooms. Not at this point.
Thank you very much. First of all, I would like to thank all the experts, Dr. Prakash, Dr. Muralidhara, Dr. Varghese, Dr. Raghu, and Dr. Shetty. Excellent, we had an excellent discussion encompassing all aspects, I think most of the aspects of heart disease, heart attacks, prevention, treatment, and even we enveloped into the diabetes bit as well. So I would like to thank the audience who's present over here. I would like to thank to hold more programs in Bangalore. Probably Bangalore has been the IT capital of India. Maybe it will lead the way to prevent more heart attacks and healthy heart lifestyle. Thank you everybody. Thank you for your presence.